Dear esteemed chair, dear esteemed colleagues, let me bring you to a slightly different territory, that is the interdisciplinary territory of psychology and gastroenterology, so psychogastroenterology. My name is Tibor Fehér, I'm a clinical psychologist, and I work at the Institute of Pancreatic Diseases, and what I bring to this team of researchers is the vision that patient care, where GI problems will be better prevented, mitigated and cured by a psychosocial medicine, is on our way, and it's our job to do it. And my mission in this vision would be to develop these exact psychosocial interventions and prevention programs that could help us in the future. Now, let me present these two topics that I have at hand. The first one is a meta-analysis investigating the prevalence of anxiety and depression in patients with pancreatitis, because at first we have to see the numbers. What do we dealing with here? Now, what do we know so far? Where's the niche, I could also say? We already know that there is a connection between the brain, the gut, the microbiome, and different psychological variables. We do know that. What we don't know is what's the exact connection between pancreatitis and these variables. Just to give you an example, we know that depression increases the risk of chronic diseases in general, and vice versa. Chronic diseases increase the risk of depression. Again, we know that, but the problem is that there is no real research focusing on pancreatitis and these interventions. So our aim would be to explore the prevalence first of anxiety and depression in patients with pancreatitis. Now, the clinical question that comes from this thinking would be, what is the prevalence using a COCO-POP framework? And our hypothesis, given the clinical work that we do at our ward, would be this: there is a high prevalence of these psychological disturbances. Now, when we did this systematic search, of course, we try to be as wide as possible. So one domain was pancreatitis, the other one was, again, as broadly as possible, the different psychological keywords, but focusing on anxiety and depression, yielding, in the end, only 44 eligible articles that we could work with. Now, so far, the prevalence data and the questionnaire data and the smoking-related data are also researched. So let me just give you a glimpse into the manuscripts because of time constraints. First, anxiety. In the end, we see that for AP, the percentage that we deal here is 23%. Now, that's for AP. For CP, the number is a bit higher, 31%. So if we move on from anxiety to depression, we can see similar results. But the first number, again, for AP, is 29, and the other one is 39. So if I were an administrator in the hospital, if I were someone who is in the position of power and who would like to argue for the need of psychologists at our ward, I would look at these numbers and say psychologists are indeed needed in these units, because it's not just some people have these conditions. These are real numbers we have to deal with. And again, if we look at smoking numbers, my problem was practically similar to Orsh's, because what we see in the clinical reality is that most of these patients are also smokers. So we took this clinical reality and we tried to research it, but given the statistical significance levels, almost non-existing, we see that there is a clinical relevance to this, but so far there's no statistical significance to this. So the strength is, of course, assessing the psychological domain as one, besides assessing the pancreatitis side, but the limitations are the enormous heterogeneity between these studies, as you could see in the meta-analysis plots. Also, there is significant differences in the outcome definitions. As you probably know, there is a difference between pancreatitis and when my tummy hurts. Same thing for psychology and psychiatry. If I'm in a depressed mood, it's not the same as major depression disorder. These two things are not similar. And this definition was not clear in the description of these studies. But still, the conclusion is rather evident. There is a considerable prevalence of anxiety and depression in these patient populations. So the implication for research, as I mentioned, would be the revision of the guideline, really. We need psychologists working in these wards, not just around these institutions, but integrated into a psychosocial team of professionals working with these patients. And implications for research, more prospective studies. There's GI psychology studies that actually follow people, because most of them were observational and retrospective studies that we could see. And our manuscript is submitted to gastroenterology, so we hope the best. Now, moving on to the second project, which is investigating the risk factors of psychological conditions and their influence on acute pancreatitis outcomes. The first one was the prevalence. Now we are into the details, if you wish. Again, what's the problem here? Where's a niche? We already know that mental disorders elevate the risk in general of adverse clinical outcomes. But for pancreatitis, we lack these very details. Just look at the graph here. If you look at the prevalence of depressive disorders in heart failure and the attributable risk, you see a connection. If I were to plot something similar for pancreatitis, I wouldn't be able to make a plot like this. So again, we need to investigate how psychological alterations may affect the clinical outcomes, or I should say the somatic outcomes of pancreatitis. So that would result in three questions. Number one, what is this dynamic change of psychological variables during the acute phase of pancreatitis? And our aim would be, of course, to explore this dynamic change as the disease progresses. The second question would be, what are the risk factors that are leading to these worse psychological assessment scores in AP? And the aim would be, again, to explore these risk factors that are more connected to these unfavorable outcomes. And the last one is, how do these psychological assessment scores influence the clinical outcomes, with the aim of investigating how psychological alterations may affect the clinical outcomes of pancreatitis. Now, looking at the numbers coming out from our institute, the first figure here is the difference between admission and discharge. So everyone who comes to our institute with AP gets a psychological and an assessment by the dietitian as well. And we see that as the disease comes to an end at our institute, there's a change in the psychological profile as well. The question is it because of the disease, people are getting better, or is it because of the psychologists working by the bedside? So we are incorporating many different gastroenterological units to join the research and answer this question. But also we have to know the difference between AP, recurring AP, CP, and all the other parts of this family of diseases, really. And we see that as the disease progresses on our parts, the psychological scores are getting worse and worse and worse. And if you ask the question, why is it that people with CP have, not always, of course, but most of the time, bad adherence, they're not necessarily coming back? Well, again, I'm not saying that these are the outcomes that have to do something with it, but they are a contributing factor to it, and also to their clinical realities as well. Also, we have to ask the question whether etiologies are connected to this business or not. So when we look at the numbers, we see that people with a background in alcohol use are leading our assessment scores when it comes to the clinical or the subclinical levels. Also, people who are coming to our institutes with tumors are probably the second in this list. So again, it's not a question of whether these things influence pancreatitis. We have to go into the details now. What are those etiologies that can form the greatest risk factors that we need to see at admission as psychologists working at these wards? And to finish these figures with the CRP levels, if we move on from mild CP through moderate CP to severe CP, we can clearly see that when my physician friends say, well, this person is in the severe type of AP, when I look at the assessment scores, I see, well, same here. So there is some sort of correlation going together with these assessment scores. Again, we are not there yet to say causation, but we do see that what we experience in the clinical realm is sort of reflected in the data. So these are the topics that I'm currently working on. And concerning additional activities, I had the pleasure of attending multiple international and Hungarian conferences, and I also took up teaching as a hobby. And please just let me finish my talk with the quote of Ralph Waldo Emerson: "The first wealth is health." Thank you for your attention.
Thank you very much for that lovely presentation. I still haven't got this right. This was an interventional study, or was this a patient registry study, or was this analysis from the literature?
The second one is a cohort analysis, and the first one was the meta-analysis.
Yeah. So your cohort where you did prospective investigating with a score.
Precisely.
What are the interventions you do? Is it psychopharmacology? Is it training? Is it behavioral training? What do you use in terms of intervention?
In literature, what's usually used in these cases are so-called LIPIs, meaning low-intensity psychological interventions. They are stemming from the school of behavioral cognitive psychology, but they're usually used in the clinical settings because we do not really have time for months-long therapies, and these are proven to be effective in the short term as well. So that's why we use them.
Very good. Thank you.
Thank you for your question.
Thank you very much for a very interesting talk. It's working. But you mentioned at the beginning that your mission would be to develop psychosocial interventions.
Oh, yes.
And what do you think, how could your specific results be translated into interventions in the future?
It's just like, I think, in the case of psychocardiology. Back then, and I can very much connect to your talk as well, back then psychocardiology was the brainchild of two people, and now it's a whole range of studies being produced at different institutes all around the world. It has a name, psychocardiology. Psychogastroenterology, on the other hand, doesn't really have that nice ring to it yet. But I believe that if we combine LIPIs that was discussed before with these results, we can create something that I would probably call gastro-oriented LIPIs that would help these patients better than the regular ones.
Thank you very much.
Thank you for your question.
Tibor, I wanted to ask you, you said that in AP cases, in 31% of the cases, the patient had depression or anxiety. And I was curious about how is this compared with the overall chronic diseases?
Mm-hmm. If we could come back to this slide, then you can see the prevalences, the word prevalence is up there on the top of this slide. If we just slow down for a bit and look at these numbers and just think back to the number you just shared, we can clearly see that these numbers exceed the word prevalences. Again, it's not like it's the hobby of Peter Hedje and I to look at psychological assessment scores. We look at them because given these numbers, these patients tend to suffer from these conditions more prevalently than the regular population. So that's why my argument would be that we should just transcend the clinical world that we have here in Hungary. It's like school psychologists. In school psychology, there are 1,000 pupils and one school psychologist. Now, the ratio of psychologists working in healthcare is a bit better, but not that much better. We need to amend that, and we would have to create a model that we try to do at PBA and try to implant that model into different gastroenterological institutions as well, because if this works, then it's our duty to make workshops, to make trainings, and to help our colleagues to bring the torch forward.
So I have a question regarding for your first project. What do you think, what is the reason behind of the higher prevalence of anxiety and depression in the chronic pancreatitis group? Yeah, this is the question.
How much time we have? It's like the age-old question of the mind-body problem, right? Back then, people were like, these are two extremely separate realms, no connection whatsoever. Thank you, Descartes, for that. But now, where we are right at in 2025 is that there are many interconnections, like the HPA axis. And that's one of the things I would like to point out. If the stress response can connect these realms, if all the sympathetic and parasympathetic responses can connect these two realms, that we are on the right track. But again, that's where we are at right now. We know the pathomechanism. We are at the door of realizing how are these things exactly connected in pancreatitis, but we're not there yet. So I hope that the work of my colleagues and mine can help us go through that door.
Great.
Thank you. So, yes.
Thank you. So first of all, thank you for the interesting topic. I'm just wondering, and I'm really interested in your professional's opinion about that, if depression or anxiety can modify or influence the personal experience of the pain or the symptoms. Yeah, so that's my question.
We have some data regarding that, but they are not sufficient. What I mean by that is we are still collecting data for the second project, the cohort project. What tends to be the picture is that the greater the pain, the greater these psychological alterations are, but this connection is not so prevalent in the first half of the VOS score. In the second part of the VOS score, it tends to be there. The answer for that, well, that could be the topic of the next progress report, probably.
Thank you for your presentation. I have two questions. The first one is your second project. Sometimes you talked about depression, sometimes anxiety. So did you check the effect of depression and anxiety alone, or just the combined effect? And the second question is, what do you mean when you are talking about depression? Okay. So are you talking about the psychiatric diagnosis, or what is the meaning of this word in your study?
Thank you so much for your question, because regarding the first one, we did check it, and we found that if we combine the effects of these two conditions, so anxiety plus depression, it was then where we could see the results, most prevalently. With anxiety alone and depression alone, not so much. There was a tendency, but the combined effect was much greater. That's for your first question, if I remember correctly. Now, for the second one, again, that's connected to many of the previous questions, because when we looked at the heterogeneity of the sample, it was enormous, ginormous, really. I mean, if you looked at if I could go back just here, for example, I mean, what is that? They are so different from one another. If you look at the two ends, like here and here, it's almost like these people were researching different things. And that's the answer. They were researching different things. Again, a depressive symptom is not the same as having the disorder itself, as you mentioned. Also, sometimes it was AP, sometimes it was recurring AP, sometimes it was severe AP, and there are so many combinations of these different conditions that when we were doing and when we are doing the cohort analysis, like, no, we need clear-cut definitions for the psychological realm and for the somatic one as well.
So we have a lot of questions, so it is so interesting topic. So my question is, you mentioned that it is bidirectional. So what is the prevalence of pancreatitis in the depression population? So which results, which has the greater impact? What do you think? What is your...
So questions about why the bidirectional?
So what is the cause and what is the result?
It's because I want to be intellectually honest. We don't know the direction at this point. And probably the answer is not as clear-cut as we would like to be. I mean, as a clinical psychologist, I would love to believe that my variables are the one that influence the outcomes of pancreatitis, but it would be too narcissistic, wouldn't it? And if we look at the effects or the studies from other diseases, it was not black and white. So why would it be so in the question of pancreatitis? So that's why I use this word bidirectional, given the literature, because that's where we are, honestly.
Thank you.
Thank you for your question.
Congrats on your progress. I had a question about these depression prevalences. How do these compare to other major systemic diseases? So why are you investigating acute pancreatitis exactly? Like, what's your take on that?
Easy answer, because everyone here loves pancreatitis and the pancreas.
I know that.
A more elaborate answer would be that when I finished my clinical psychological training, I knew that I wouldn't want to be that clinical psychologist who opens the door to his client, he or she comes in, I do the therapy and I write all the documentation, and then they leave, and then on repeat for hours. I wanted to find an applied field when I can do patient work, where I can do research, and when I can teach. And Peter Hegyi had a nice solution to that problem.
Okay, fair enough. Thank you.
Congrats for presentation. I have a question about, we saw that in chronic pancreatitis, these conditions are more prevalent compared to acute pancreatitis, which kind of implements that the more time a patient battles with this disease, the more he or she battles with anxiety or depression. Will you, in your cohort, examine these time-related factor with different time points?
Very good question. And again, the honest answer I can give you is this: at this moment of time, we are not yet following them, but we can see, when we look at it from a cross-sectional point of view, that there is a connection between chronicization of the condition and the worsening of my outcomes. But in order to really say that there is a connection, we would need a longitudinal follow-up methodology that we not yet have, but we will in the future.
But this longitudinal follow-up, is it too hard, or what's the why don't you do that?
Two answers to that question. The first one is something that my colleagues here would probably know, is we have a lovely study called Reappear at our institute, which is for people who drink and then who also smoke. And we try to call them back, like, come back, here it is for free. You know how much a psychologist costs nowadays? A lot. So here is it for you for free. And you can come here every 3 months for the duration of the study. And it is excruciatingly hard to reach them and to have them come back. And again, it's in a way connected to the fact that people suffering from addictive disorders tend to act like this in real life and in scientific world as well, I mean, as patients. So first answer, it's very difficult to reach these patients, and we are trying newer and newer ways to solve that. And second one is, we had human resources for these methodologies so far, but now that more and more colleagues are coming, we can improve.
Thank you.
Thank you.
Any questions? I also have a question. Can you just clarify how the diagnosis was made during hospitalization or throughout the course of the disease? Because we know obviously that chronic pancreatitis is a much longer time period than compared to acute pancreatitis. How was this evaluated?
I wouldn't want to evade your question by saying it was the job of my physician friends, but that would be my honest answer. I mean, we have a big table of every single data we have of our patients at the ward, like psychological scores, dietetical scores, etc., etc., etc. And the nature of their disease is also included in this registry. Like, I can see whether this patient has AP, CP, or recurring AP, and I could put my variables in the other column so that we can do these analyses. But these were, as far as I'm concerned, done during hospitalizations. And of course, sometimes they already come with the diagnosis, CP patients tend to turn out more frequently at our ward.
Like, so a CP patient had like anxiety or depression before hospitalization or after hospitalization, that wouldn't be considered, or it would be considered as an event?
Sure. I was talking about the somatic part
because
here,
then that can explain why it's much more common in CP than AP, because of course you're looking at a much longer timeline. So
true.
And even if you don't have AP, I mean, the chance that you get depression and anxiety eventually during your lifetime is quite high anyway.
Yes, what we see is that, that's true, number one. Number two is that what we see is that these prevalences are higher than that of the general population. Yes, every one of us experience anxiety at some point of our lives. Well, not everyone, but we are probably not antisocial here. So everyone experiences these symptoms, but not everyone experiences that sort of anxiety that we're talking about here.
Tibor, you mentioned in the first study that you also analyzed some scales or psychology scores. Maybe due to time you couldn't show us the result. Could you say something about that? What kind of scores did you use, and what was the results compared to the general population?
Right. We used the hospital anxiety and depression scale. For one, we used Spielberg, we used the Beck, so all the mainstream questionnaires were found in the data. But again, there were some that are minor questionnaires that couldn't be pulled together. So these three were the most prevalent. And what we see is that the same as here for the prevalences, when I mentioned that the prevalences for the general population are way lower than the prevalences that we've seen. Same goes for these psychological questionnaires, which sort of proves our point further. It's not just the prevalence that's higher, but also more people are above the clinical threshold that I would call clinical level depression and not subclinical or normal. Thank you.
Thank you very much for
Thank you very much.
presentation.